Everyone. My name is Denise Octavia Smith, and I'm the founding executive director of the National Association of Community Health Workers. I am so excited to welcome you to this first spring webinar series for NACHWA. I bring you greetings from Hartford, Connecticut. With me on the call are our administrative coordinator, Nina Schultz, and our presenter for today, Dr. Ashley Wenterstrom. A couple of things before we begin. I'm going to ask that everyone stay muted for the duration of the presentation. We want to get through those slides so that we can open up the chat box for questions. Please look for the chat box feature now and let us know if you're having any challenges with that, and we'll scroll through and read those questions. Next slide, please, Nina. So I'm so excited to welcome all of the members of NACHWA from around the country, our allies and supporters, and everyone who's joined the call today. I'm thrilled to open up this discussion to our community across the country to continue the foundational work of NACHWA, which is to center and elevate the profession of community health workers in its many forms and cultures and origins. Community health workers are a timeless workforce, deeply rooted in compassionate service and in community and lived experience. The trust that we have from the community is because that's where we come from. It is not just service, it is a calling for many of us. And so the pictures that you see before you are not stock photos. They are actual CHWs conducting the work. Some of them are educators at community colleges. Some of them are preventing community violence. Some of them are working towards immunizations and working on diabetes prevention, and some are moving policy and legislation. And in so many areas, CHWs have proven their effectiveness and impact. CHWs are centered around health equity, which means we're considering and concerned about the whole health and well-being, not just of individuals, but of communities. We are also leaders in our respective states and regions, and increasingly at a national level, impacting health and social service systems and driving equity. Next slide, please. So a little bit about NACHWA. If you haven't had a chance to visit our website, if you just became a member so that you could be a part of this members only webinar, our vision is uniting community health workers across the country, across ethnicity and culture and geography and experience. And we're doing it in a couple of essential ways. We're engaging across the CHW community, inclusive of our allies, our supporters, and our partners, our sponsors, and those who are influencing the workforce. We are expanding our membership across the country through our ambassador program, through our newsletter, and through many other avenues that I'll talk about later, so that we can expand and provide opportunity and also unite for collective action. We are enhancing the existing CHW leadership skills because our leaders across the country, you're already doing the work. You have proven your effectiveness, and you are concerned about and involved in the decisions that are being made about your community and your state. And so we want to lift up CHW leaders and provide training and technical assistance so that they can continue their goals and aims for their community. We're educating stakeholders that may be partners or sponsors or allies on the impact of CHWs. One of the ways we'll be doing that is pulling together a national database where people can find and identify not only best practice, but actionable programmatic work about CHWs. We know that there's much about our work and impact, our models, our perspective, our origins. Those stories and that data has not all been collected or lifted up. And so we're working hard to pull that together and make that available. And as we have launched the National Association in 2019, we are establishing a national and sustainable voice and an infrastructure so that we can move policy and strategy on issues related to the CHW workforce. Next slide, please. NACHWA is a values-driven member organization. And as such, we're leading with, we're developing partnerships centered in our values. As an organization that is concerned about health equity and social justice, we're rooted in concepts and we're advancing policies around self-determination and self-empowerment. We believe in the dignity and respect of all human beings. We believe in the integrity of our cultural origins and the models of CHWs that have come from our culture and spiritual traditions. And we endeavor to unify this workforce across the country so that we can learn from one another, network together, and support one another as we transform the health of our communities. Special shout out to our partnerships. There are CHW networks and associations across this country who are doing great work supporting local CHWs, building infrastructure, and we just want to thank you for lifting up the workforce in your local area or region over all of these many years, some new, some old. We want to lift up our allies and supporters who have conducted the research that confirms the excellence and the effectiveness of CHWs. We want to thank our sponsors who have invested in this workforce and believe that we are a present and future public health workforce capable of transforming systems and impacting health. Next slide, please. So want to just give you a little bit of insight into our national membership, and then I'm going to get out of the way quickly so that our keynote speaker can have the floor. The map that you see before you just is highlighting where our membership concentration is. We're just looking at the top 10 states around the country with the most members. And you'll see that Texas is #1. So shout out to everybody from Texas. I was born in San Antonio on Lackland Air Force Base, so I'm partial to it. Texas has the most members for NACHWA, but you'll also see that states like Hawaii has the #3 rate of membership in terms of NACHWA, but we are in 46 states across the country. The next slide, please. A few more points of data about our membership, which is just under 500 members nationally for individual CHWs. The top areas of work based on the data that was shared with us from CHWs when they became members include community organizing and outreach, working in health clinics and offices, conducting health education and coordinating care services, conducting home visits, and also being involved in research. And the primary areas of expertise are varied. You see that CHWs are working across every conceivable sector, not only working for specific disease states, but also focusing on gender-specific health issues and services, considering maternal and child health across the spectrum, but also dealing with issues of immigration status and resources and support, supporting housing and basic needs, addressing economic opportunity, and many other areas. And these are just our top areas from our data. We also have a number of CHWs working on the opioid epidemic as well. Next slide, please. And then this final point of data is just where we're seeing some of our membership. Not all of individual CHWs who are members of NACHWA are formally employed. Many are promotoras, or they are lay health ministers or volunteers who identify as CHWs. But for those of our members who are employed and identify themselves as being employed, this is where they're working. And again, we are moving not just throughout health systems, but you can see that the #1 employer of members who are employed include community-based organizations. And oftentimes those organizations are not just working on specific grants for a specific disease state, but often they're addressing the social drivers of well-being or the social determinants of health. Next slide, please. So we're inviting you to connect with us. We're a young organization. We were launched in April 2019 as a 501c3, and I was so fortunate to come on as the founding ED in November. So I'm on my 5th month, and I want to thank all of you for your well wishes, the many emails and connections that folks have made with me already. But we're asking for you to connect with us. Become a member or share this membership opportunity with other CHWs so that they can get connected to the National Association. Take time to review and share our newsletter. We are including in that newsletter information about our annual meeting, the great information about our ambassadors. These are CHW leaders across the country and the great work that they're doing. We're sharing information, webinars from partners across the country, ways that you can provide continuing education and professional development for CHWs. And we invite you also to take that time and share with us opportunities that you might have in your local area that we can share, job opportunities or other local events. You can use our Connect With Us page, and you can send a job opportunity or post a question, and we'll endeavor to connect with you as soon as we can. Next slide, please. And finally, you know, this webinar series came out of the work of the NACHWA Policy Committee. It's a committee that is staffed not only by our board, but also by CHWs. And in conversation with some of our members, some of our partners, and some of our ambassadors across the country, the conversation about certification has come up numerous times. CHWs have asked for NACHWA to create a platform, a space where we can begin to consider some of the challenges and approaches to certification if states are moving in that direction. And so I want to say just a couple of things as we open up the presentation to Ashley so that she can provide her expertise and lessons learned. NACHWA as a national organization, as a member organization, does not endorse any specific training program or curriculum. For CHWs who are looking for continuing education, training programs, we ask that you network with other CHWs, that you look for CHW training programs that are co-created, led by, and co-taught or taught by CHWs. NACHWA does endorse the following APHA policies, and these are just high-level summaries, but we invite you to visit our website and click on the policies page, and you'll see a complete listing and detailed information. There are policies that we're highlighting on our website, including the 2001 APHA policy, highlighting and confirming CHW's many contributions to US health systems and health outcomes. The 2009 policy from APHA confirming and endorsing CHW effectiveness to address health inequities in the United States and abroad. And the 2014 APHA policy in support of CHW self-determination, and a policy that endorses that 50% or more CHW participation on any workforce or decision-making board with policies, regulations, training, curriculum, or employment concerning CHWs. So we want CHWs to have an equitable, equal, or greater representation on those decision-making boards. We're always trying to center and elevate the CHW voice, not only as direct service or frontline public health workers, but also as leaders for our workforce and to transform health systems. And so with that, I am so excited and so grateful that Ashley Wenterstrom agreed to kick off this webinar for us today. It's called To Certify or Not to Certify, and Ashley's excited to provide insights on states' experiences with creating CHW certification programs. Briefly, let me just introduce her. If you didn't have a chance to read her bio, Dr. Wenterstrom is an associate professor at LSU Health Sciences Center in New Orleans. She's been a proud ally of the community health worker workforce for over a dozen years, focusing on workforce development and policy, and she conducts community academic partnered research focused on promoting health equity. She currently co-leads the Louisiana CHW Workforce Study Committee, and that's co-leading with another CHW. And she previously served as chair of the American Public Health Association Community Health Planning and Policy Development section. And with that, I'm so happy to welcome Ashley.
Great, thanks so much, Denise. I really appreciate it. It's really wonderful to be here today, and I thank Denise and all of the members of NACHWA who were kind enough to invite me. So one of the things that we've been experiencing, and I should say I'm a proud founding board member of NACHWA, and I'm currently co-chairing the NACHWA Policy Committee along with Darrell Fox, who many of you likely know. One of the questions that we've been getting is what's going on with certification, and are there any insights that we can provide? So today I'm going to be talking a little bit about a study that we did a couple years ago in partnership with many collaborators. If you want to move to the next slide. Just want to acknowledge that this project was done in partnership with a lot of different folks. The research I'll be describing was led by Carl Rush, who many of you likely know, as well as Terry Mason and my awesome colleague Meredith Sugarman, who works here at LSU with me, and then also several colleagues at the CDC, and this study was funded by CDC as well. So we can go on to the next slide. I just want to start briefly with the definition of community health workers. I'm sure that probably every CHW presentation you've ever seen in your life starts with a definition, but I think it's important just to make sure that we are all on the same page about who we are talking about. So this is the APHA definition that is endorsed by the National Association of CHWs, as Denise was just describing. But really the key piece about community health workers is that you all are trusted members of the communities that you serve. And then we can go on to the next slide. And because you all are trusted by the communities you serve, there are so many important roles that you can play in terms of building individual and community capacity and really trying to address the underlying social determinants of health that cause health inequity in the first place. And of course, I think we all know that CHW is meant to be an umbrella term. So probably many people who are on the webinar today have some other job title like an outreach worker or a community health liaison, or perhaps a community health representative or a promotora de salud. All of that falls under the community health worker umbrella. So we're talking about everyone when we're talking about CHWs. We can go on to the next slide. I won't go into great detail about this. If folks want more information on any of the studies that I'm just going to mention very, very briefly, feel free to contact me later. But there is a lot of evidence that community health workers are incredibly effective in improving health outcomes in a number of important health issues like diabetes, cardiovascular disease, asthma, and cancer. CHWs can reduce healthcare costs and unnecessary utilization of healthcare services, reduce hospital admissions, increase preventive behaviors like cancer screening, and then, as I mentioned earlier, really act as advocates to change policies that affect social determinants of health. So very upstream approach. And next slide. So for all these reasons, because we know community health workers can improve health outcomes and save money, improve patient experience of care, and change the underlying drivers of health inequity, community health workers have become a very, very popular workforce in recent years, which has led to a lot of questions about, how do we support CHWs? How do we expand and grow the workforce, and what does that look like? And so it's important to keep in mind that the vast majority of community health worker workforce development and policy really happens at the state level, which allows for a lot of flexibility. And it also means that there is just a lot going on around the country all the time, and it's difficult to kind of keep track of what's happening because we have different experiences in every single state. Some of the elements of CHW workforce development include establishing a CHW definition and standards. The definition that I shared earlier was a definition that's commonly used, but some areas opt to use different definitions, so it's important to know about that. There can also be issues related to what sort of training CHWs in any given area might have, or what kind of work experience might be required for them to get a job as a CHW. Workforce development can also include promotion of hiring and integration of community health workers into both public health and healthcare systems. And then career and leadership development are also important elements of CHW workforce development. So moving on to the next slide. So certification has become very, very popular in recent years in a lot of states. It's growing. So roughly 20 states, and I say roughly because things are constantly changing, have implemented or are considering some sort of process for certifying CHWs. But the challenge is that there's really not a lot that's already known about the best sort of processes or practices to use to develop and implement certification. And this is a really important question because other states may go on to implementing certification. So this became a really interesting research question that we wanted to look into. And I want to be very clear that this study was done in such a way that we're not trying to promote certification. We don't think that it's the be-all, end-all. We really were just trying to figure out, among states that have chosen to implement some kind of CHW certification, what can we learn from them? And I just want to reiterate that NACHWA does not have a specific stance on CHW certification. So with that said, we'll move on to the next slide. So what is certification? Let's make sure that when we're talking about that, we understand exactly what we mean, because this word gets used a lot. So basically, certification is some kind of process to document the skills and qualifications of an individual to perform the roles or duties of a community health worker. So in order for someone to obtain a certification, they might need to go through some type of formalized training program. There may need to be some sort of assessment, and an assessment could be a formal written exam. It could be done through practical skills demonstration. There's a number of ways that assessment can be done, but oftentimes a certification does require some kind of formal assessment. Often there's continuing education. So just like a lot of health professionals like physicians or nurses or social workers that have to do ongoing continuing education, that could be a requirement for CHW certification. And then in order for a certification to exist, there has to be some kind of overseeing body. So somebody or a group of somebodies that sort of determine whether certification requirements are met and are being kept up to date. So when we think about that, it's important to consider how this could affect the CHW workforce. And effects could be positive or negative. Having certification could affect the titles that CHWs use. It could affect their scope of practice, certainly could affect compensation, could affect relationships with other health professionals. Again, could be positive or negative, but we really just don't know. Moving on to the next slide. As we're talking about certification, it's really important to make sure that we distinguish it from a couple of other things with which is often confused. One of those is a certificate of completion. A certificate of completion is usually issued when someone finishes some sort of training program. So I, for example, have a CHW training program here in Louisiana where I live, and when people complete my program, they receive a certificate of completion that says you went through this training program, but it does not mean that they are certified. It just means they went to the training. We also want to make sure that we distinguish certification from licensure. And licensure is a little bit different in that it is usually reserved only for clinical roles that have the potential to do great harm to public health. And we know that community health workers do non-clinical work. Even if they're working in a clinical setting, they're not performing any sorts of medical procedures. And therefore, it's generally understood that licensure is not needed for CHWs. But sometimes people sort of use the term certification and licensure interchangeably and just want to be mindful of that and understand that there's actually a significant difference between the two. Moving on to the next slide, please. So this slide was developed by Terry Mason and Carl Rush, who were members of the study team, as well as Jeff Wilkinson, who's one of the founding board members of NACHWA. They've done some work around certification and have created this sort of list of various important elements that need to be considered whenever certification is going to be developed. And we'll talk more about several of these in just a couple of minutes. But those include the definition of a community health worker and core competencies within any given state, scope of practice, and how CHWs are distinct from other professions, practice standards. If certification is going to be implemented, there's got to be some sort of process for assessing whether the person trying to become certified is proficient in the skills that are needed. There's got to be some sort of eligibility and application process. There has to be an administrative home. So again, sort of who's going to be the overseeing body, who's going to make sure that certification is carried out, and how will that be paid for. Continuing education requirements are also an issue. And then it's important to consider whether there will be any procedures to renew or revoke existing certification. Next slide, please. There are also different models of certification. So certification could be made mandatory or voluntary. It could be done at an individual level, at an employer level, or training programs or instructors could be certified to deliver a particular curriculum. Certification could be administered by a state, some sort of private entity, or a CHW-run organization. It can also be implemented through the use of legislation, as we have seen in some states. So point being here, there are a lot of different ways to do it. And again, we don't have a whole lot of information about what is the best way to do it. Next slide. So we decided to carry out a study, again, with generous funding from the CDC. And basically what we wanted to do is look at specific state level actions and organizing structures related to CHW certification. So basically, you know, among states that have implemented this, how did they decide to do it? And what do the structures look like? So we reviewed documentation on legislative, administrative, and financing supports for CHWs in all 50 states, plus Washington, D.C., and Puerto Rico. We created a set of criteria to help us select the states that we wanted to work with. And that included states that were at various levels of certification, either in the process, had implemented quite a while ago, or were had implemented in the reasonable past, not too far in the past. And we also wanted a nice geographic distribution of states. And so ultimately we identified 7 different states to include in our study. So I'll move to the next slide. And the next one. Great. So the methods that we used, so we conducted once we selected our 7 states, we conducted key informant interviews. Basically, we want to go and talk to the people who'd been involved in these processes. So CHWs, of course, were at the top of our list of folks to speak with. We also talked to state health officials, payers, particularly Medicaid, and CHW employers. And then we did interviews with them. So Terry and Carl, who worked on the study, did all of those interviews. Those were audio recorded and then transcribed. And then Meredith, my colleague who also worked on the study, and I worked together to do some in-depth qualitative analysis of those interview transcripts, and we used applied thematic analysis techniques. I won't get into the nerdy details of all that, but if any folks are interested in research, want to talk more about that, again, feel free to contact me afterwards. So we can go to the next slide. So what did we find? We ended up completing 41 interviews. And so the chart that I have here is kind of a description of where each state was in terms of the certification process, and then the number of people in each category that we spoke with. I am sure that at least one person listening to this right now is questioning, well, which states did you pick? Who did you talk to? The answer is we are keeping that information confidential. When we reached out to people to participate, we wanted to maintain their confidentiality. We wanted to make sure that they would really tell us the truth about their experiences and what they thought worked well with implementation and what they thought did not. So we are not revealing the names of the states that we spoke with, but as you can see, we did have a variety of states. So we ended up speaking with one state that had considered but not implemented certification, 3 that were nearing implementation, a couple that had implemented less than 5 years ago, and 1 that had implemented more than 5 years ago. We were able to speak to CHWs in all states except for 1. And then we had pretty good representation from state health departments and employers in all of the other states. And we were able to talk to Medicaid staff in just 2 states. But ultimately, we ended up talking to a total of 41 people. Next slide. And what we found were that there were 3 main kind of key themes that came up. So I'm going to go through those now. The first one was just sort of what people considered before they implemented certification. And above all, the first thing that we found was that states have to decide whether certification is necessary in their state or desirable. So among those that did, the reasons that they said that they wanted certification is they wanted to help professionalize the workforce. There was a lot of sense that having a certification would increase credibility with other professions, so other non-CHWs like physicians and nurses, and perceived financial stability. So there was a lot of discussion about how certification could help lead to some sort of Medicaid reimbursement. And as we all know, the community health worker field has really struggled with funding CHW positions on a sustainable basis. Most of the time funding comes from grants that can end very quickly. Among those states that decided not to certify, the reasons that they cited were barriers for CHWs. They felt like it just wasn't feasible. And there were concerns about the integrity of the profession. So as one employer said, CHWs were essentially concerned that their profession would be co-opted by other people making rules about what their skill set would be. So I thought that was a nice quote. Moving on to the next slide. Some other important considerations among those states that decided to implement certification. One of the things that they had to consider was what kind of education and experience requirements they would implement. They had to consider whether certification would be mandatory for anyone who is a CHW or whether it could be a voluntary certification. They considered whether there should be some kind of training in core competencies, how long that should be, who should offer that training. And then there was also a lot of discussion about whether there should be some sort of certification based on experience. So for example, if there's a CHW that's been doing this work for 10 years, do they need a certification, or is there a way to demonstrate that based on their experience, they can become certified rather than having to go through training and jumping through a whole bunch of hoops. Continuing education requirements were also an important consideration. So how frequently, what would those continuing education units look like? How would they be offered? Who would pay for them? And then costs, of course, were a very large consideration. And a lot of people were concerned, or at least, expressing that they had to consider whether CHWs would be able to afford certification or whether perhaps employers would pay for that. Next slide, please. Another major consideration was what entity would administer a certification process. So again, whether that might be the state, some sort of private entity, or whether there was a CHW association within their state that would be appropriate to do that administration. And then another really big consideration that came up in basically all of the states was trying to make sure that community health workers are truly members of the communities that are served. So, theoretically, anyone could apply for a CHW certification, go through a training, go through some sort of assessment and get their certification. Well, those of us who work with CHWs and who are CHWs really understand that that alone doesn't make somebody a good CHW. It's the connection that they have with their community. So states had to consider, what kind of a process they would go through to make sure that someone who was intending to go through certification truly had the trust of their community so that they could be an effective community health worker. Next slide, please. There was also a lot of discussion about making sure to avoid marginalizing some community health workers. So for example, people who are working in non-clinical settings, and this applies to a lot of NACHWA members. As Denise was pointing out earlier, a lot of our members work in community-based organizations. So we want to make sure that we're not sort of separating those folks out and putting too much burden on them. There was also some concern that there are a lot of very effective community health workers who may not be US citizens, and so we don't want to create a barrier to allowing them to do their work. Also, there are many effective CHWs who primarily speak another language, and so we'd want to be mindful of any certification process being able to accommodate different languages. And then finally, the issue of background checks came up because we know that some CHWs may have a history of some kind of involvement with the justice system, and that certainly does not preclude them from being very, very effective community health workers, and in some cases may make them more effective. And so we want to make sure, or states were trying to make sure that that wouldn't marginalize that group of potential CHWs. Next slide, please. Another important area that came up in all of our discussions was sort of the factors that influenced whether CHWs were able to participate in certification discussion. Again, this is really important. I just want to highlight what Denise was talking about earlier with the American Public Health Association policy on community health workers self-determination. We know that we want any entity that's making decisions about the CHW workforce to really be led by and driven by CHWs and should be at least half CHWs. So our question was, how do we make sure that happens? In states where they were successful, they felt like some things that promoted CHW participation in these certification and workforce development discussions were support from state leaders. So state leaders really recognizing the importance of CHWs being at the table and having leadership roles. Presence of an organized CHW group, like a state network or association. Some sort of support for travel to meetings, because oftentimes meetings happen in areas where CHWs do not live, and then support from employers to participate as well. Next slide, please. There were also a lot of barriers to participation, and in some cases, CHWs were just not actively listened to or included. And I love this quote that one community health worker shared with us. They said, someone from the state came and said, what do you think about the idea of certifying CHWs? And I said, that's a stupid idea. But really, it was not a question. Later on, I figured out it was a statement. You are going to have certification. So this is what can happen when CHWs are not actively included. They get sort of told about what's going to happen to them. In some cases, employers didn't provide time for CHWs to attend meetings. Logistics were very challenging in terms of time constraints of travel, particularly for community health workers that lived in rural areas when meetings were more likely to be in urban areas. And in some cases, CHWs and others felt like the certification process was driven by state or academic institutions, which made participation either not possible for CHWs or not attractive to them. Next slide, please. And then finally, one of the main themes that came out of our work were sort of the effective practices in community health worker workforce development. So one of the main things was just having a clear definition of who the workforce is, and that's why I always start every single presentation I ever do about CHWs with the definition to make sure everybody's on the same page. Because oftentimes, as I'm sure you all have experienced, there's a lot of misunderstanding about who CHWs are and what they do. And I will say that a lot of people specifically mentioned using the APHA definition of CHWs. Defining a scope of practice was also considered to be a really important and effective practice in developing the workforce, again, to sort of clarify who falls into the workforce, who doesn't, what people do and what they don't. There was also a lot of reference to the Community Health Worker Core Consensus Project, or C3, as it's often known, and how that was a useful guiding document. For those who are not familiar with it, I would point you to it because it is a useful document in my humble opinion. And the website for that is www.c3project.org. Next slide, please. And some additional effective practices, not surprisingly, involve CHWs in decision making. And there was a great quote about that. A CHW said, "There's a saying that says nothing about us without us." So basically, we don't want decisions made for us. We want to be involved in these decisions. It could very much affect the way I do my job, or how I'm paid, or who comes on board. So that was just one sort of exemplar quote. Another important thing was to educate stakeholders about CHWs, so just to make sure that people working at state health departments, people who are working in clinical settings, really have a good idea of who CHWs are, what they do. Moving on to the next slide. Additionally, there were various approaches to implementing certification. And so the overall takeaway there is that it's not just a one-size-fits-all model. There's any number of sort of right answers in terms of how to implement certification among states that choose to do that and feel it's a good fit and CHWs want it. Very important to learn from research and technical assistance from other states and from national organizations. Another thing that came out a lot was the importance of identifying workforce champions. So a lot of people talked about how helpful it was to have somebody working either within a state health department or within the legislature or some other sort of key decision-making body that could advocate on behalf of CHWs and what members of the workforce wanted. And then finally, one of the most effective things that people talked about was convening stakeholders. So they were saying, we've got all these different people and stakeholders who are interested in the process, be it CHWs, state health departments, academics, state health plans. So the idea was that there has to be some central organization that's willing to convene people, even if it's just planning meetings and getting them together, taking notes, planning the conference call, facilitating dialogue, all of that. Next slide. So finally, just kind of in conclusion to this piece, if certification is to be implemented in any given state, and if is in bold, it should be done with CHW leadership. It should be done because CHWs in that state want it, and it should provide support for their involvement. Community membership is a key qualification of CHWs that came up over and over again, really making sure that certification takes that into account, making sure that folks who are going through a certification process truly are trusted by their communities. Education about community health workers is essential. Again, just sort of broad scale education campaigns to let people know more about what the workforce does, who CHWs are. And then finally, a convener is necessary. So somebody's got to help convene the process. Next slide, please. We do not have a lot of time, so I'll just mention very briefly a few notes from down south in my home state of Louisiana, where I have lived for many, many years now. So as Denise mentioned before, I've been working in partnership with CHWs for a long time. I think I said over a dozen years, close to 15 at this point. One of the things I was proud to do is help found our local community health worker association here, which is called LaShawn, the Louisiana Community Health Outreach Network, several years ago in partnership with a community health worker named Catherine Haywood. But recently we got, about a year ago, we were approached by some state health department leadership who said, hey, we think that it's time to start certifying community health workers in Louisiana. And so Catherine and I and other colleagues said, well, how do we know? Do CHWs want that? We don't really know. And so what we ended up doing, rather than moving forward with implementing certification right away, is we ended up getting a legislative resolution passed to create a community health worker workforce study committee. Say that 5 times fast. But in any case, Catherine and I had the pleasure of co-leading that over the course of about 9 months. And so what we ended up doing was convening a whole bunch of different stakeholders from around the state who are interested in CHWs. So CHWs themselves, members of the Office of Public Health, folks who are involved in Medicaid managed care. We created members of the study committee, which was at least 50% CHWs with a CHW co-lead. And then we conducted a statewide study of community health workers, all CHWs and all their employers that we could track down. I could do another webinar on the findings from that. But we did an online survey, we did paper surveys, so there was a quantitative piece, and then we also did in-depth interviews with CHWs and their employers. And based on that study, which we just wrapped up, we created a list of recommendations for the Department of Health about how we should move forward with CHW workforce development in the state. And so I was proud of that process. There's still a ton of work to be done, and who knows what will happen next. But we were proud of that process, and a lot of that was informed by what we learned in the certification study, which is about really finding out what CHWs want, taking the time to invest. And I will just say that as my last piece before I go to questions. Above all, I would say don't rush it. If you're in a state where things are being considered, or you think you'd like to pursue certification in your state, all I can say is just really, take your time to make sure that you get the right stakeholders involved, if that's what's appropriate in your state. Next slide. This is just contact information. This is my contact information. My colleague Meredith, who I mentioned, who works just down the hall from me. And then our wonderful colleague and friend, Catherine Haywood, who leads LaShawn, Louisiana Community Health Outreach Network. She's been a CHW for several decades and is also a founding NACHWA board member. So feel free to reach out to her if you want to have perspectives of a CHW on the ground in Louisiana. With that, I will be quiet and be very happy to answer any questions that I can.
Thank you so much, Ashley. It's been great just to sit back and receive all of that information. And I was scrolling through to see everyone on video, intently watching the presentation, answering a couple of basic questions. Of course, we will share the slide presentation. So for all of you who've asked, absolutely. I've also posted, if you have any questions, please post them now. I'm starting to see some questions come in. This final slide, just as I wait for questions to come in, you see that this is the beginning of a webinar series. And so we've posted the titles and the dates and times. All of these are Eastern Standard Time for the next webinar coming up March 24th. At that webinar, you'll hear from a promotora from Puerto Rico who is now living and working in Connecticut, who led the process in my home state of Connecticut. I'm a CHW and have been for 15 years in Connecticut, and was able to participate in that process. So you'll hear from her. You'll also hear from a state agency representative, and also from a community-based organization and advocate who worked on the legislative side. So you're gonna start to meet the teams that come together to have these conversations and make some of these things happen. So please save the date. Look for our newsletter that will be coming out next week. If you're not a member, join our membership. It's $20 for new CHW members, and we'd love for you to stay in touch. So Ashley, I'm just gonna go to a couple of questions. The first is from John. Why do some states use a legislative process and some don't? What's the value of either approach?
Ooh, that's kind of a tough question. I mean, honestly, every state just sort of does what they think will work for them. And I think it really depends on who it's coming from and how things are done. So I just want to say that I'm talking now not about anything from the study itself, but just my own, general knowledge and experience in working in this field. So Texas, for example, was the first to implement legislation around CHW certification. My understanding of what happened there was that it was very much kind of a top-down approach. It sort of came through the legislature because there was interest in it. Does that approach work? I mean, sure, it effectively established certification, but did it bring CHWs into the process? Not necessarily. Then we can look at a place like Massachusetts, which, what my colleagues in Massachusetts have always explained is that they opted to do a legislative approach, but they did it in a way that was very much inclusive of CHWs. They established a process to include CHWs throughout the entire process of developing standards and all that, but it's taken them a very, very long time to implement. So I guess the point there, legislative approach can certainly be led by CHWs and be effective, but it also can be very top down. I think the value of the approach really is that once it's codified in law, it's generally not going anywhere. So if that's what CHWs want, that could be an effective approach, but it also can be difficult to change. I hope that answers the question.
Mm-hmm. There's a question from Danny, and the question says, let's see, are there articles debunking the myth that certification brings recognition and buy-in by health institutions? And so there seems to be an underlying statement there that it is a myth. And so you've just talked about a broad process and not too much data on long-term impact of certification. So I think that's important to point out, but what would be your comments there?
Sure, that's a good one. And hi, Danny. Danny always has the best questions. We've known each other for many years and she's wonderful. It's a really good question. I mean, honestly, I don't think that there has been much, I mean, not that I have ever seen, there's been very, very little research on the impact of certification, and partially because it's relatively new in most places. So I think the answer is that we don't know yet. I think there needs to be a lot more research about that. The way the question is listed is that it is a myth. I think we don't know just yet. So hopefully there will be more research, and if I ever find some spare time, maybe I will be happy to do some of that myself.
Mm-hmm. Yeah, and it's important to restate that CHWs are not always looking for certification simply to prove the profession to others, right? That there is a process and a structure that CHWs may want to put in place for their own integrity of the profession. And so I think that's important as well.
Yeah, and any given CHW may have their own motivation for it. So yeah, that's a good point.
There's another question. Why is certification not tied to reimbursement? Are there any states that do that? Well, that's interesting.
Okay, let me think of how to answer this appropriately. So it's really sort of two separate issues. So a state can implement certification, a state can implement reimbursement. They can do both. They can be tied together, but they don't have to be. So for example, the state of Minnesota, as I understand it, has had CHW reimbursement through Medicaid for quite a long time. Mm-hmm. However, they generally don't talk about their program in terms of being a certification program. Usually they'll talk about it as a standardized training program. But I think the larger point is that it's really two separate lines of action. So you can have a certification program, but that doesn't automatically mean that Medicaid is going to want to pay CHW. I also just want to point out that when we're thinking about community health worker payment through Medicaid, I would really recommend that we talk about not just reimbursement per se, because that tends to sort of steer our thinking towards a fee-for-service model. And what we have seen with that is that so far, among the few states that have implemented something like that, the uptake has been very, very limited because a lot of providers don't know CHWs can be paid that way. That's one issue. The bigger issue is that a lot of the billing codes for CHWs don't really cover the full scope of what CHWs do. So for example, a billing code might cover something like but that might only cover, say, 15 minutes for that CHW to sit down with a patient. But it doesn't cover all the times that a CHW has to make phone calls to that patient, or the times that a CHW invests a whole bunch of time in getting that person connected to resources to address some of the social issues that are really impacting whether a person is able to make their chronic disease. So when we're thinking about Medicaid payment for CHWs, We really want to think about more sort of global payment or per member per month payments and things like that that really allow CHWs to sort of do the full scope of their roles, or if there's some way to make direct reimbursement a little bit more flexible, such that CHWs could really, carry out the full scope of their roles.
Thank you. Are there any final questions? We're almost at time. Okay, I'm just going to scroll through the chat.
Don't be shy.
Okay, well, I'm going to take this moment. Just going to continue to watch the chat box, but I'm going to take this moment that we have so many CHWs on the call, just to highlight that earlier today, the World Health Organization did categorize the coronavirus, COVID-19, as a pandemic. I have received in the last week emails from many NACHWA members and partners asking for resources and information for frontline workers, for people who are conducting home visits, for community health workers in a number of different settings. The first thing I just want to say is that NACHWA, all of us, we care, and we are thinking about you and praying that you are adopting behaviors related to self-care. And I want to let you know that while I have found few national resources that are specifically targeted towards CHWs who are conducting home visits, who are working in community, I found lots of information for medical providers, for health systems, for lots of, correctional officers, and I've found lots of information for the general public. But for frontline public health workers who are likely going to continue conducting home visits, visiting shelters, providing direct service, NACHWA is going to be curating and pulling together some resources from trusted sources. We're working with the Centers for Disease Control to try to highlight the information that they have that's vetted. And we also want you, if you are employed, to make sure that you're working with your employer, community health organization, community-based organization, so that you have resources for your health. And many meetings are being canceled and folks are trying to figure out whether or not they should go forward. You want to use your own values in terms of personal safety. Please make sure that you're lifting up conversations and concerns that you have with your supervisors and with your employers. If you are a volunteer CHW, you can certainly reach out to us or make connections with your local network or association. But we want to acknowledge that we are still committed to our communities, and we recognize that people who could be most affected may be people who do not have access to health care, they don't have health care coverage, they're homeless, their health systems are compromised, and we know that CHWs are often serving and caring for many of those communities who experience vulnerability. So I appreciate, again, the commitment and the service, the heart that you extend to your communities. But if you are not well, you cannot care for others. And so we want you to practice safety. Of course, the CDC has lifted up the coronavirus.gov website. There's lots of information there. It is difficult to find some information from frontline workers. But yes, I will be sending out that resource early next week. It'll be in our newsletter. If I can get it out sooner, I will, but we're really trying to lift up some sort of advisory for NACHWA so that we can disseminate that information to members to guide your work. Remembering, of course, that you want to connect with your employer, you want to connect to your local health department or your state health department for information and updates on cases, preventive measures, closures, and all kinds of adaptations for health and safety. Yes, and as soon as I release that information, you are free to share it with CHWs. And yes, someone did mention that there's a webinar today, and I will be later on today for frontline workers. I know that many of you may not be able to attend. I will be distributing the slides from a presentation from later today and vetting those resources for our membership. Okay, I don't see any other questions related to the webinar. I want to thank Ashley again for bringing this information to us. We really hope that it will help you wherever you are in the process. And we know that CHWs and their respective states are all in different places in this process of contemplating certification, trying to grapple with a definition for your state, convening advisories and work groups to have conversation. And we hope that you follow up with Ashley and with her team members to glean the steps in the process so that you can consider and take the time, as she mentioned, to ensure that CHW voices are centered, that there is at least 50% representation on those work groups for decision-making bodies, and that you consider a broad community of CHWs who might be impacted by this movement for the state, recognizing that we work across sector. So thank you so very much. And with that, we thank you and we'll close the webinar. We hope that you'll join us for our next webinar on March 24th. And we'll be sending out in the newsletter the way that you can register. Have a safe afternoon, everyone. Take care.